Hello. My name is Jones, and today we are going to look at HIV-associated neurocognitive disorders. Okay, so this is abbreviated as HAND, like hands. The hand. Okay, so in looking at HIV-associated neurocognitive disorders, we want to understand the psychiatry aspect of HIV infection. Okay, so HIV-associated neurocognitive disorders are neurological disorders that are associated with HIV infection and AIDS. It is a syndrome of progressive deterioration of memory, cognition, behavior, and motor function in HIV-infected individuals during the later stages of the disease, when the immune system has been rendered defenseless, or when there is increased immune deficiency. HIV-associated neurocognitive disorders may include neurological disorders of various severity. The neurocognitive disorders are associated with metabolic encephalopathy that is induced by HIV infection and fueled by immune activation of macrophages and microglia. These cells are actively infected with HIV and secrete neurotoxins, or toxins that are toxic to the neurons. So they secrete neurotoxins of both hosts and viral origin. The essential features of HIV-associated dementia, which is abbreviated as HAD, okay, disabling cognitive impairment that is accompanied by motor dysfunction. There might also be some slowness or trouble with memory and poor concentration. Motor symptoms may include loss of motor control leading to clumsiness, poor balance, and tremors. Behavior changes may also be seen with people with HIV-associated dementia, and it may include apathy, lethargy, and diminished emotional response. And also in the motor area, we also see a reduction in spontaneity or spontaneousness of doing things. Histopathologically, it is identified by the infiltration of monocytes and macrophages into the central nervous system, gliosis, pallor of the myelin sheaths, abnormalities of dendritic processes, and neuronal losses that can be seen within the condition. So our topic that we are looking at is an HIV-associated cognitive disorder, which is abbreviated as HAND. Okay, so when talking about this, we see an array of a lot of diseases. Okay, and these may be associated with encephalopathy that may be induced by HIV infection due to fueled immune activation that affects the macrophages and microglia. This then triggers the release of neurotoxins, that is from both the hosts and those from the virus. Okay, so let us look at the neurodevelopmental disorders that can be associated with the HIV. Okay, we have to look at the neurodevelopmental disorders that can be associated with HIV. When talking about mother-to-child transmission during pregnancy, okay, neurocognitive disorder or neurodevelopment disorders can be seen because HIV can still be transmitted from mother to a child, or there are associated risks of transmission of HIV infection from the mother to the child. Children with AIDS appear to have neurological diseases as a consequence of HIV-1 infection. In HIV-1 infected newborns and children, central nervous system is infected with HIV-1 weeks after primary infection. This then will cause neuronal damage and cell death. Although neurologic dysfunctions have been associated with HIV infection over the central nervous system, it is unclear how the pathogenesis of neurologic disorders can be fully established for these children. Otherwise, the main cells infected by HIV-1 in the nervous tissue are the microglia, astrocytes, and the macrophages. Okay, so when these are infected, neurons have been also observed to be affected by HIV infection. Okay, so neurons can also be infected by HIV infection. So the susceptibility of HIV infection and the replication in neuronal and glial cells is a function of cellular differentiation, and it is more likely in immature precases than with differentiated cells. Several soluble signals such as cytokines have been described to modulate susceptibility and can further contribute in supporting virus latency or virus replication during organ development when looking at mother-to-child transmission or infection affecting the brain development in children. In fact, within developing central nervous systems, cells are under the control of environmental factors that are of specific function of neuronal and glial precursors. These extracellular signals can influence many steps of the central nervous system development and concur in controlling virus cell interaction in the maturing brain of the newborn or developing baby. In addition to the production of cytokines, HIV-1 infected mononuclear cells and astrocytes can produce a number of soluble mediators, including viral proteins such as GP120 or glycoprotein 120 and also TAT that can exert damage effect on both developing and mature neural tissues. Moreover, molecules such as platelet activating factors, okay, that is PAF or platelet activating factors, and prostaglandins, which are produced upon microglia or macrophages and astrocyte functional interaction, they may have been reported to mediate cell damage in primary neural cell culture and neural cell lines with the immature phenotype. When there is activation of the macrophages, there will be production of prostaglandin and platelet activating factors. When these are produced, they further affect maturation or interact with maturation of the brain, leading to neurodevelopment disorders for these children or for these cells that are maturing. Taken together, these observations suggest the mechanism by which the virus can alter central nervous system development and induce pathology in the immature brain, that depend upon the altered production of soluble bioactive compounds. The compounds that we have mentioned, like prostaglandins, protein activating factors. Several potentially neurotoxic mediators have also been identified in different model systems, including inflammatory cytokines, viral proteins, and neurotoxic metabolites. So we can say it is likely that a complex interaction of several mediators may, after the function and survival of actively developing and maturing cells, be responsible for the neurotic disorders that can be seen in this child or in this person who has developed some HIV infection with increased immunodeficiency. Then when we talk about HIV-associated dementia, typically it occurs after years of HIV infection and is associated with a low CD4 cell count and also high plasma viral loads. So these two factors, low CD4 count and high plasma levels, may increase the likelihood of one developing HIV-associated dementia. It is sometimes seen also as the first sign of the onset of AIDS. As we know, AIDS is the end stage of HIV, where one has an acquired immunodeficiency syndrome. Prevalence of HIV-associated dementia is between 10 to 24% in Western countries and has only been seen in 1 to 2% in people of Indian origin. And with the advent of the highly active antiretroviral therapy, the incidence of HIV-associated dementia has declined in a lot of developing countries. Although its prevalence is increasing because of some people that may be developing AIDS, we have seen the incidences of HIV-associated dementia decreasing. Highly active antiretroviral therapy may prevent or delay the onset of HIV-associated dementia in people with HIV infection, and may also improve mental function in people who might already have HIV-associated dementia. Dementia only exists when neurocognitive impairment in the patient is severe enough to interfere markedly with day-to-day function. That is, the patient is typically unable to work and may not be able to take care of themselves. Before this, the patient is said to have a mild neurocognitive disorder. So let us appreciate the presentation of some of HIV-associated cognitive disorder. So cognitive impairment associated with HIV occur in the domains of attention, memory, verbal fluency, and visual spatial construction. Specifically for memory, the lowered activity of the hippocampus changes the basis of memory encoding and affects mechanisms such as long-term potentiation. Severity of impairment in a different domain vary depending on whether or not a patient is being treated with highly active antiretroviral therapy or monotherapy. Studies have shown that patients exhibit cognitive deficits consistent with the dysfunction of the frontal striatal circuits, including associated parietal areas, the latter of which may account for observed deficits in the visual spatial function. In addition to cognitive impairment, psychological dysfunction is also noted. For example, patients with HIV have higher rates of clinical depression and alexithymia. Okay, so that is difficulties processing or recognizing one's own emotions. Okay, then patients also have more difficulties recognizing facial emotions. Okay, so without a combination antiretroviral therapy, cognitive impairment increases the successive stages of HIV. HIV patients in early stages show mild difficulties in concentration and attention. In advanced cases of HIV-associated dementia, speech delay, motor dysfunction, and impaired thoughts and behavior are observed. Specifically, lower motor speeds were found to correlate with hypertrophy of the light putamen. The diagnosis of HIV-associated neurocognitive impairment is made using clinical criteria after considering and ruling out other possible causes. The severity of neurocognitive impairment is associated with a low CD4 count, as we have already stressed, suggesting that the area treatment to prevent immunosuppression due to HIV, might not have really helped. But if you use highly active antiretroviral therapy to achieve immunosuppression, then you are less likely to see HIV-associated cognitive disorder. Okay, so let us also appreciate the brief pathophysiology of HIV-associated neurocognitive disorder as we look at the HIV, the psychiatric aspect of HIV. Okay, so the brief pathophysiology that I can talk about to do with HIV-associated dementia or neurocognitive disorder is that when you talk of HIV-associated dementia, it is not a true opportunistic infection. It is one of the few conditions caused directly by HIV itself. However, the cause of HIV-associated dementia can be difficult to discern because the central nervous system can be damaged by a number of other causes that are related to HIV. So when you're talking about HIV-associated dementia, it may come because of opportunistic infection that may affect the brain. Okay, so these opportunistic infections, when they affect the brain, it may lead to what we may term as HIV-associated dementia. Then we can also talk of AIDS-related lymphoma or metastasis of other AIDS-related cancers that may affect the brain and lead to HIV-associated dementia. Then there can be direct effect of the virus to the brain, and this may lead to HIV-associated dementia. The toxic effect of drugs for treatment of HIV may also affect the brain and lead to HIV-associated dementia. Okay, not forgetting that mostly HIV may affect people in low-income areas, so malnutrition may also lead to HIV-associated dementia. Many researchers believe that HIV damages the vital brain cells, neurons, indirectly. According to one theory, HIV either infects or activates cells that protect the brain, And these we have discussed, these are known as macrophages and microglia. These cells then they produce the toxins that can set off a series of reactions that instructs neurons to self-destruct. The infected macrophages and microglia also appear to produce additional factors such as chemokines and cytokines that can affect neurons, as well as other brain cells known as astrocytes. The affected astrocytes, which normally nurture and protect neurons, also may now end up harming neurons, so becoming neurotoxic. Astrocytes produce neurotoxic proteins such as TAT, NEF, and RAVE. TAT is secreted and induces the activity in the astrocyte through increased GFAP expression. HIV protein GP120 inhibits the stem cells in the brain from producing new nerve cells. In the neuronal cells, the HIV GP120 induces mitochondrial death proteins like caspases, which may influence the upregulation of death receptors FAS, leading to apoptosis. Okay, so let us also now understand, as we understand this pathophysiology, let us also understand the stages of HIV-associated dementia. So it has got 6 stages. Okay, so there's stage 0, there's stage 0.5, there's stage 1, 2, 3, and 4. So stage 1 is the normal stage. Then stage 0.5 is the subclinical stage. Then when you talk of stage 1, then we are saying mild, stage 2, moderate, stage 3, severe. Then when you talk of stage 4, that is the end stage. So when you're talking of stage 0, which is the normal, here we don't see any, we see normal mental and motor function. That is in stage 0. Okay. So this is the first stage of HIV-associated dementia, and the stage 0, on which everything is just normal. That is the mental and motor function. Then when you talk of stage 0.5, that is the subclinical stage. Here, there are minimal symptoms of cognitive or motor dysfunction, okay, which are characteristic of HIV-associated dementia. Or we might see mild signs, okay, or SNAT response, slowed extremity movements, but without impairment of work or capacity to perform activities of daily living. Okay, so here the gait and the strength are going to be normal in the subclinical stage. Okay, so we see SNAT response, slowed extremity movement, but the gait and the strength of the patient remains normal. That is in the subclinical. But when we reach stage 1, the mild, here we see evidence of functional, intellectual, or motor impairment with characteristic of HIV-associated dementia. But here the patient is able to perform all activities of daily living and can walk without assistance. Okay, so in stage 1, patient is able to do all activities of daily living and can walk without assistance. We only see evidence of functional, intellectual, and motor impairment that is characteristic of HIV-associated dementia. When it reaches stage 2, which is moderate, here patient cannot walk or maintain the more demanding aspect of daily life, but will be able to perform basic activities of self-care. Patient may be ambulatory but may require some help, maybe to stand up or to be propped up before they can walk on their own. So that is stage 2, moderate. Okay, the ambulation here is with some help as the patient starts to walk. Then when you talk of stage 3, that is the severe stage. Here we see major intellectual incapacity. Here the patient cannot even follow news or personal events nicely and cannot sustain complex conversation. There can be considerable slowing of all outputs and all motor disability. Here, patient cannot walk unless with assistance, or may require a walker or personal support, usually with slowing or clumsiness of arms as you are assisting the patient. So stage 3 is the severe form. Then stage 4 is the end stage of HIV-associated dementia. Here, I can say this is patient is nearly in vegetative state. Intellectual and social comprehension and responses are at their rudimental level or are at rudimentary level. Nearly or absolutely, the patient is going to be mute. Patient may be paraplegic, and we might see urinary incontinence and also fecal incontinence. Of course, these are the HIV-associated dementia stages. There are 6 stages. Start with 0, 0.5, then we have 1, 2, 3, and 4. So we need to remember stage 0 is for normal, and we are looking at 2 aspects, intellectual and motor response. So stage 0, intellectual and motor response is okay. Then stage 2 is subclinical, may not require admission or clinical attention, but may have minimal symptoms of cognitive or motor dysfunction. Here, patient begins to show some problems in intellectual or cognitive function and also in motor functioning. Okay, but can do all activities of daily living and gait and strength and everything is normal. But when we reach stage 2, it's no longer subclinical. Here, patients may seek help from the hospital because there is evidence of functional, intellectual, or motor impairment. They might be able to perform more demanding aspect of work or activity of daily living, and patients may walk without assistance. But when it reaches stage 2, patient will need assistance to walk, and here patient fails to maintain demanding aspect of daily life. When you're talking of stage 3, which is severe before the end stage, here the patient, even if you force them to walk, you see some clumsiness in their arms as they carry out this task. Okay, then stage 4 is the vegetative stage. So if you have revised the lesson about levels of consciousness and the likes, I'm sure you can understand HIV-associated dementia stages. Okay, so now in appreciating our lesson to do with HIV-associated neurocognitive disorder, we are still stuck to the DASH model as proposed by myself. But when you're looking at the HIV aspect of, let's say, marijuana, we use the DASH model. And then when you're looking at the HIV aspect, the psychiatry aspect of HIV, then we can still use the DASH model. So what I'm simply saying is, in the psychiatry aspect of marijuana, we use the DASH model, which for DASH is more like an acronym of the common diseases that are seen. So now, for this presentation, we have seen that depression can come in. Okay, clinical depression can come in. We can relate it to the encephalopathy, okay, the depression that may come in, or we can relate it to the lost days that one may have because of constant sick of. So they may end up depressed because of lost income. Okay, so if there is encephalopathy, then
delusions may come in, or psychotic conditions may come in. Then prominent within our discussion is HIV associated dementia. So dementia is also part of our DASH model of the proposed conditions that are seen as the psychiatric aspect in a lot of situations. Okay, delirium, of course, this will be seen because we have a patient whose levels of consciousness may be affected, as seen within the discussion to do with HIV associated dementia. So if the level of consciousness is being affected, delirium is likely to be seen. Okay, then suicidal ideation may come because of the stigma associated with the disease. Okay, so suicidal ideation may be seen or become prominent because of the fear of whatever comes with the disease process. So this is just one of those. So proper counseling is important as treatment to this suicidal ideation, depression. Okay, then we can also see problems to do with stigma and discrimination, of course. Okay, and we can look at it or appreciate it more to do with the psychiatric aspect of it. We may have sleep disorders that may come just before depression, or that may come during depression. Okay, in trying to associate HIV within mental health. Okay, we can patient may have some sleep disorders because of worrying about opportunistic infections that may be affecting them. Okay, so these are just some of the few conditions within the DASH model that we can try to appreciate that is seen in HIV, or when talking about the psychiatric aspect of HIV. We can talk of depression, we can talk of dementia, we can talk about suicidal ideation, we can talk about sleep disorders. And even when you talk about substance abuse, it can also apply with that is to do with the psychiatric aspect of HIV or mental health. Substance abuse may come in because substance abusers, most of the time, they will not care even if they use needles that are infected. Just because of the addiction that they have, they may take high risk behaviors, okay, and not make correct decisions because they just want to put that drug within their vein so that they feel better. So they may start exchanging needles. So in substance abuse, you can try to relate it in that way. Okay, then other conditions here that are within the DASH model, of course, we have depression, delusions, dementia, okay, delirium, then anxiety, anorexia, suicidal ideation. So within this DASH model, what we are saying is that it's not everything within this model that you can say is the psychiatric aspect of that condition. What we are simply proposing is that most of the things that we have put within this DASH model become the psychiatric aspect of most conditions. If we talk of HIV, you talk of epilepsy, alcoholism, child abuse, you might likely see these conditions that we have proposed in the DASH model. Okay, so there you have it. Today we are looking at HIV associated neurocognitive disorder, which is abbreviated as HAND. Okay, so these are neurological disorders that are associated with HIV infection and AIDS. And
HIV-associated neurocognitive disorder are a syndrome of progressive deterioration in memory, cognition, and behavior, and also motor function of a person who is infected with HIV due to immunodeficiency or severe immunodeficiency that may come because of HIV infection. So, apart from HIV-associated neurocognitive disorder, the prominent condition that we see is HIV-associated dementia. So, within this discussion, we have discussed the stages of HIV-associated dementia, and we have also looked at the pathophysiology of HIV-associated dementia. We have talked about the many things that can be affected when someone has HIV-associated neurocognitive disorder, and some of the condition of concern is clinical depression that the patient is likely to be diagnosed, which can be associated to HIV or neurocognitive disorder. Then we have also looked at other conditions in our summary, like suicidal ideation as one of the conditions that may come. And we have tried to associate substance abuse as one of those HIV-associated psychiatry aspects. When we are trying to appreciate the HIV psychiatry aspect. So substance abuse comes in because substance abusers, because of their addiction, they may lose their inhibition to use infected needles or needles that are not necessarily safe. Hence, they might find themselves injecting themselves with HIV. So you can have a lot of reasoning around the DASH model, because the DASH model simply simplifies those conditions that can be related as the psychiatric aspect in epilepsy, marijuana, child abuse, and other conditions, because it is also very, very important as a student of psychiatry, as a subject or discipline. But we understand why someone would want to, let's say, look at suicide in a form of mental illness, or look at it in terms of psychiatry. What would be the reason one would want to commit, let's say, suicide? So some of the things that may come is issue of depression, problem with coping, stress coping mechanism, isolation. All those can come in. Others, they might be having some delusions or hallucination as one of the reasons that may lead to suicide. Of course, please, you have to look at our DASH model with caution, because as you have seen when we have looked at HIV-associated psychiatric aspect, we have come up with new conditions that are specific to HIV, like HIV-associated dementia. And also HIV-associated neurocognitive disorders that we have talked about, like clinical depression. So you are free to add in maybe other things that we might not have considered, but we know this DASH model is quite helpful in knowing the psychiatric aspects of HIV. We might not have talked about other things necessarily because they might not be part of this presentation, but we have looked at the pathophysiology of how this is coming in. So the central reason as to why we have HIV in associating with mental illness is because of the encephalopathy that will come in. And we appreciate that we have highly active antiretroviral therapy that is reducing the prevalence of these HIV-associated neurocognitive disorders. So from me, I'm saying thank you, and keep studying.